Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everyone. Good afternoon, good morning, wherever you are. I'm Dr. Albarrak. I am a epileptologist and intraoperative neurophysiologist. Neurology Solutions from Saudi Arabia, in collaboration with the Global Innovation LLC from US, are glad to sponsor this webinar, which is under supervision of Saudi Neurology Society and accredited by ASCAT. This webinar is organized by Academy of Sciences. Today, we will shed the light on an important field in neuroscience. We will be speaking about intraoperative neurophysiology and its impact in medicine. For this, we are very happy to have a distinguished speaker with us today to speak about it. We have Dr. Faisal Jahangiri, who is an international pioneer in intraoperative neurophysiology and monitoring, and the president of Innovation LLC in Dallas, Texas. Dr. Jahangiri, over 20 years of experience in intraoperative monitoring. He monitored and supervised over 16,000 surgeries across the globe. He has published extensively, including 5 books on intraoperative neurophysiology. He offers consultation worldwide. He is assistant professor and teaches at the University of Texas at Dallas, and adjunct professor at Albarrak College of Care in Massachusetts. Dr. Faisal is a past president of the American Society of Neurophysiology Monitoring. He holds a medical degree from Khyber Medical College in Pakistan and completed postgraduate work in biomedical engineering at Case Reserve University in Cleveland, Ohio. Dr. Jahangiri also is a board certified by American Board of Neurophysiology Monitoring. He has been working at multiple institutions in US, Saudi Arabia, Qatar. Excitingly, he has also developed 6 months of online diploma, a postdoctoral fellowship program in surgical neurophysiology monitoring, and is currently teaching it. So we'll have the lecture today. It will be 90 minutes, 1.5 hours. Then after that, we'll be having a 30 minutes Q&A from the audience. Please, if you have any questions, type it in the Q&A section, and we will be discussing it after the lectures. With this, I welcome Dr. Faisal. The mic is yours.
Thank you, Dr. Anas. First of all, I'd like to thank Dr. Anas and Academy of Sciences for inviting me to give this lecture and giving me the opportunity. So I'm very excited to speak to everyone who's online, and maybe people are watching online. So today we are going to go and talk about the implication of intraoperative neurophysiological monitoring in medicine and healthcare. It is a very broad topic, and the time limit, so every single topic covered in this presentation can take few days to discuss. So it's a very 50,000 feet view. So, and I hope everyone will get the benefit of that. And if you have any question, you keep, and we are going to try to do as best as possible to answer your question at the end of this session. So in summary, so I'm just going to go through the introduction. We are going to do introduction and then discuss how we can enhance the patient safety using intraoperative neuromonitoring. What are the different types of modalities we covered? How to improve the patient outcome by utilizing IONM, and how to advance the surgical precision. And then we're going to summarize at the end with some publication. So typically what happens is every patient who go for surgery, we have to wait until the end of surgery. Surgery can be 2 hours long, it could be 12 hours long, it could be 15 hours long, 20 hours long. So and when the patient wakes up, if it's spine surgery or brain surgery or cardiac surgery or ENT surgery, type of surgery, vascular surgery, we don't know what will happen post-operative. We can predict, but if the patient cannot move one leg or the other leg or one hand, or cannot hear, have a hearing loss or visual loss or memory loss, we cannot tell what happened exactly at what time. Even we can have a guess, so there's pressure on the spinal cord or the ischemia to the brain or stroke. The time is very critical because more time we wait, uh, the changes are irreversible. So if the patient has ischemic to the brain, the gray matter ischemia can be irreversible after 4 minutes. 9 to 11 minutes may be reversible after 20 minutes, reversible change under normal temperature. So you can take the patient back, open the spine, open the brain, and try to decompress and do something, but it's already irreversible damage. So what we can do is we can use the intraoperative monitoring and monitor the patient continuously. And if there's a change, we can identify it within seconds to minutes and inform the surgeon. And whatever happened, we know what happened in a few minutes, and we can reverse that steps. It may be pressure on the spinal cord or brainstem. It could be just a decrease in blood pressure or mean artery pressure. So, or just the position. Sometimes the position of the patient can cause pressure on the brachial plexus, and patient will wake up with the numbness and pain in the ulnar nerve for the rest for many months. So that can be identified and reversed. So that's the main purpose. So what is the intraoperative neurophysiological monitoring involves continuous monitoring of the patient nervous system, including the brain, brainstem, spinal cord, and nerves when they are at risk surgical procedure. Now, high-risk surgical procedure definition is relative. Surgeon may or a physician can say, okay, this is not a high risk or high risk. For a patient point of view, all the surgeries are high risk because once they are going into under anesthesia. So the main purpose of using intraoperative monitoring is to protect the patient nervous system. So according to American Society of Neurophysiological Monitoring, or ASNM, uh, neurophysiology monitoring is defined as any measure which is used to assess the functional integrity of the peripheral nervous system or the central nervous system, either in the operating room, ICU, or any acute care center. So the need for IM are that because of the risk they are associated with the surgery near neural structure, the impact of complication to patient outcome, and then the role of IM mitigating the risk and improving the outcome. So IONM improves the patient outcome by minimizing the risk related to the functional status of the nervous system. And any alert when we identify and alerting the surgeon can help the surgeon to identify the change, the reason, and it can uh, take the action and reverse the lost procedures to minimize any post-operative deficit. So neurophysiology is another broad, very broad terminology, and I can divide into like four major topics. Number one is diagnostic neurophysiology, which most of people are familiar with. Uh, Diagnostic neurophysiology are the tests, like all the tests we do, they're called modalities to diagnose a disease. So we can do EEG for epilepsy, or visual evoked potential for MS, and EMG for neuropathy or myopathy. We do hearing tests for auditory and visual tests for vision, and we do transcranial Doppler for vasospasm. All these, so they use the modality, these tests to diagnose a disease. That we diagnostic neurophysiology. Some of these tests can be used to check the prognosis of the patient, how the patient is doing. Patient may be in the ICU, subclinical seizures. Patient can have subarachnoid hemorrhage and induced coma. Patient can have cardiac arrest, myocardial infarction, and induced coma. So we can do every 6 hours, 88 hours, once a day, evoke potential and EEG, and we can identify is the patient going to get better or worse. So we can do prognostic testing. Some of the tests can be used for therapeutic purpose. For example, deep brain stimulation is approved for Parkinson's disease by FDA, essential tremor, dystonia, epilepsy, and other disorders, OCD, obesity, epilepsy. We can use pain implant, identify the area of the pain in the spinal cord, and implant spinal cord stimulator, which can alleviate the pain in patients who have failed back syndrome or patients who have trigeminal neuralgia. We can, and they don't reply to the rhizotomy or ganglionic block. We can identify the face area and implant a stimulator on the cortex and connect it to the battery, and it causes numbness in the area of the brain, in the face, and can minimize that. The fourth one is surgical neurophysiology, which is also known as intraoperative neurophysiology. So that's the focus of our presentation today, and that's so using all those modalities, most of them in the operating room to minimize the post-operative deficit. So that's surgical neurophysiology. So we use the surgical neurophysiological modalities test intraoperatively, and because the nervous system at risk due to surgical manipulation, it could be because of mechanical insult, there could be ischemic changes, there could be thermal injuries, it could be positioning changes. So there are different reasons that can cause changes, and the neurophysiological testing to that area which is at risk can help us. So the IONM industry been growing significantly over last few decades. So just a report, Kegler report from 2015 to 2019, it grew at the rate of 8.9%. And then from 2020, the predicted value was growth at more than 10%. Uh, there are more than 500,000 surgeries performed in US under intraoperative monitoring, and there are a lot of surgery which are not being done so far still. And there are many reasons. What is the importance of doing the intraoperatives? There are different type of surgeries, such as orthopedic surgery, neurosurgery, ENT surgery, cardiac surgery, even plastic surgery, urological surgery, where the nervous system is at risk. So the INM can effectively identify and help the surgery, and it has been proven that the literature has been published for last more than 40 years about the benefit of utilizing different tests in different type of surgical procedure. So the main three benefit, if you have to boil down to three main things. So the main three benefits are increasing safety of the surgical procedures. So when we use IONM in any procedure, we put the nervous system at risk. It increases the safety. It can help the surgeon more. You have more eyes and ear, and because you're getting live in real-time feedback. The surgical centers or the hospitals, they can accommodate more complex cases, because if you have more complex cases, so you don't have to refer to a bigger center or center where they have more intraoperative monitoring. So because having an IONM during more complex cases can give you more um, uh, 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 confidence that you can accommodate them and perform them without damaging the patient. It also decreases the risk of adverse surgical outcome, and also burden on the families post-operatively. So here's a quick list of different type of surgical procedures. Is not a complete list, but many surgeries where I have done monitoring, and then monitoring can be done. Neurosurgery, for example, brain tumors, brain aneurysm, microvascular decompression of the cranial nerves, cortical stimulator implants, spinal cord tumors, resection, intradural, extradural tumors, peripheral nerve injuries, peripheral nerve tumors, Parkinson, deep brain stimulator, DBS cases, tether cord syndrome, quad iconus surgeries, selective dorsal rhizotomies, and then vascular surgery, bypass surgeries, aortic surgeries, carotid surgeries, transcranial artery revascularization, TCAR procedures. Orthopedic surgery have a big application, including any spine surgery, cervical, thoracic, lumbar, sacral surgery, trauma, subluxation, uh, scoliosis surgery, any minimum invasive surgery. So you're doing minimal invasive surgery or lateral or extreme lateral or oblique cases, or uh, you're putting the nerves more at risk. So we can do monitoring hip surgeries or total hip surgeries, acetabular surgeries, uh, and also vascular tibial surgery, and fibular osteotomies, ENT surgery. So ENT surgery, parotid tumors, thyroid tumor, facial nerve tumor, cochlear implant, ossicle um, implants, all these surgical procedures, and general surgery, nephrology, for example, nephrology surgery, sometimes they're doing a big tumor in source major, and you have lumbar plexus at risk. And then I have, there's a paper published from the University of Virginia that they did study on Da Vinci procedures. So procedure done under Da Vinci in hysterectomy procedure, 6.7.1 patient have woke up with ulnar neuropathy because the position caused pressure on the ulnar nerve, which has nothing to do with the surgery. It was 7%, 7.1% for the big, and they wanted to have monitoring for us. And then prostate surgery monitoring is being done for prostate surgery, and the papers have been published and it's still in progress, but that's also another avenue. So what's the need of evidence of value for IONM? So we already have enough evidence. IOM is based is compelling pathophysiological and probabilistic rationale. The absence of randomized human outcome studies is no accident, because in light of animal data, that human experiment would be unconscionable. It's we cannot do. It's not possible to do a blind study or double-blind study to confirm or uh, to about the application or benefit of interpreter, because in order to have a blind study, one group will not get the new monitoring, or the one group the monitoring, or they're not going to tell the surgeon if there's a change, to see if the change means patient has so if there's a change during, so if you're doing surgery, two groups, one have 100 patient, the other have 100 patient, we ethically is we cannot say, okay, these patients are not going to, they need the neuro monitoring because that can help them, and then we are not going to do that. We can also cannot do that. We do neuro monitoring on both of them, and one group is not going to get a feedback. The surgeon is not going to get feedback because we want to confirm that if there's a change and that correlates with the true positive, and the patient is going to have a deficit. So that's the dilemma, and we cannot do that. So, and that also applies for another scenario, which is parachute. So that's a good example. So I thought maybe I'd like to share with the audience. This is a paper which was published. So ethically, we cannot do a blind study on have two groups of people, one jumping with a parachute and one jumping with a backpack. And say, okay, let's see the people who jump without parachute have injury, because we are not going to, we know they're going to have major trauma or they're going to die. So, but this paper, this is an interesting paper. So somebody want to read, published recently in 2018 in British Medical Journal, about the uh, should use to prevent death and major trauma when jumping from the aircraft. So their conclusion was that parachute use compared with the backpack control did not reduce death or major traumatic injury when used with participant from the aircraft in the first randomized evaluation of the intervention. This is a very alarming and very eye-opening conclusion, that two backpack jumped and one jumped with a parachute, and there's no statistically difference, and both have the parachute did not induce injury. But if you go to the brain, go to the flow of chart, no, they have 60 participants and 65 refused, and the one, I think the 24 they enrolled, they refused to jump from. So everyone jumped from 1 foot. So that was, so everyone jumped from a stationary plane, and they compare the data, and there was no difference. So kind of sarcastic paper, but interesting comparative, which can be applied for interpretive modeling. So let's go back to the INM. So high risk surgery, what is high risk surgery, and how we can enhance the patient safety in the surgery? So just giving you these surgeries like spine surgery or trauma surgery with severe trauma to the spine. When we are trying to do the correction and trying to fix that, we are technically causing the same trauma again. We are going to move those vertebral body again, and those the nerves and all the spinal cords at risk. So having the sensory and motor function monitor can minimize any deficit. Scoliosis surgeries also can benefit from neuromonitoring, because when we are doing correction on these scoliosis patient, all and can cause further elasticity. We don't know, because the kid is going, the patients are going, how much elasticity these patients have and how much they can tolerate. So patient may have 100% correction and paralyzed. So you don't want to do the 100% correction in patient when you lose the signal. So we don't know we can stop at, we have to stop at 70% correction or 90% or 80% correction unless we are doing intraoperative monitoring. So if this is a patient on the left side and we are want to make it straight with after full study, all the function, lower motor functions, sensory function, bowel function, they are all at risk. So we have to monitor all of them. And when we are doing the correction, the surgeon is doing the correction, we cannot afford any loss of these functions and have to stop at the level. Spinal cord tumors, intramedullary tumors, extramedullary tumors, all these tumors, they also put the spinal cord and nervous tissue at risk, depending cervical, thoracic, lumbar, quad equina. They put motor function, sensory function, all and bladder function. If it is at a cervical level, it affects all. So having an eye and having model neuromonitoring can help in these patients and the surgeon. Split cord patient with a split cord, patient with a tether cord, lipomeningeal, all these patients, when you are going to identify and correct those spurs, find that the phylum and remove the phylum and differentiate the phylum, and patient with a fatty phylum can put all these function at risk. So having dorsal root rhizotomy, again, if you are doing dorsal root rhizotomy without monitoring, just cutting randomly 30–40% of the rootlets. But selective rhizotomy, which we are going to discuss all these cases in following slides, help us identifying the rootlets and cutting the only selectively abnormal. So we don't want to cut the normal root because patient will have more, may have functional loss. Spinal cord stimulant implants, patient surgical procedures, and they are considered as failed back surgery syndrome. They are good candidates. They are some other exclusion. So they're the good candidates. They can get the spinal cord implants, and in the past, these implants were implanted in a weak patient to localize the plant with the patient has pain in the right foot. So you have implant located on the file which are close to the right foot. And we turn on the battery and we see the patient have a numbness invariably. So the implant, the continuous current cancel out the pain fibers most of the time, and then it causes paresthesia in those areas. But during the closing, it take more difficult having a patient awake in supine position. So with the neuromod, EMG, and collision studies, and SSCP, and all the motor evoked potential, we can do 3 cases surgical procedure in the time you take 1 or 2 cases. Brain surgery again, because these tumors or cyst or aneurysms or AVM, they can shift the corticospinal tract or motor fibers or language fibers, anterior, posterior, medial, lateral, inferior. We cannot tell on the surface. If we have advanced technology in imaging, we can have diffuse tensor imaging, we have MRI, CT scan, but you open the brain, there's also risk of brain shift and all these. So we can do the anatomical area may be different than functional area. So the functional area can move, and so we can help this patient because the patient motor function, sensory function, and language function will get risk in these patients. CPA tumors, brainstem tumors, all the cranial nerves, brainstem function, motor and sensory function, hearing, cranial of 5 to 12, 4, 6 to 12, all the nerves are at risk. So depending on the size of tumor, you can monitor all the cranial nerves. So the only one we don't do intraoperative monitoring is the first olfactory nerve, but from optic nerve to 2 to 12, we can monitor all of these in different procedures. Again, in the patient with this MRI, so patient contralateral motor function at risk, sensory function at risk, the language function at risk. So having the monitoring in these procedures can help them. So how we do that? So this is just an illustration that is a surgeon is working here. This is surgical size, so we are stimulating depending on sensory fibers. So sensory fiber we stimulate from periphery and record from the brain, and for motor we stimulate from the brain and record from periphery. So the surgical side is in the middle. So if the signal is transferred and have no change in latency, the signal remains the same, and it has no decrease in signal, we don't need any intervention. But if there's an injury can be mechanical, it could be thermal, it could be ischemic, and that injury can decrease the signal or have signal loss, or it take longer time the signal loss. We need intervention, and we can get the information immediately instead of waiting for 6 hour surgery. So that's the very summary of every modality. So different modality, visual testing is different, auditory is different, sensory different, motor different methods to do that. But the purpose is to identify the injury between the stimulation side and the recording side. So if we have a good monitoring, and these are all spine cases, brain cases, patient will have a good outcome. If the patient is poor outcome, patient have more deficit, paralysis, weakness, and it could be temporary, it could be permanent. Patient can have facial paralysis, patient can have hearing loss, and other deficit, language, memory loss, depending on surgical site. So, but we can minimize these by identifying on time and then helping these patients. So IONM helps to improve the patient outcome by minimizing the risk related to functional status of the nervous system during all these procedures. And ION alert to the surgery team can help them identify and take immediate corrective action. So let's go to the operating room and talk about the more detail about neuromonitoring. So the modalities are the specific, as I mentioned earlier, specific electrophysiological test we are used for monitoring the nervous system. Most of them, they are listed here. The SSEP, the short version. These are somatosensory evoked potential and used for monitoring the ascending pathway. For sensory pathway, transcranial TCMEP or transcranial magnetic electric motor evoked potential. Also, MEP motor evoked potential is for monitoring descending motor pathway. COMEP, which is corticobulbar MEP, is for motor pathway, but for the head and neck nerves. BAP is the brainstem auditory evoked potential for monitoring auditory pathway. VEP for visual evoked potential for visual pathway. EMG is for monitoring peripheral nerves and the cranial nerves, and can be done by either trigger EMG and spontaneous EMG. EEG and electrocardiography, which is done for monitoring the brain waves. Then we can do transcranial Doppler during the surgery, also for especially carotid endarterectomy, to identify the emboli. We can count the number of emboli and can stop the maneuver. DECS or DEX is direct electrical cortical stimulation for mapping of the motor brain and for the language area, and MER is for microelectrode recording for deep brain stimulation. So these are the modalities of somatosensory evoked potential, motor evoked potential, brainstem auditory evoked potential, EMG, EEG, electrocardiography, recording the brain waves directly from the cortex for more epilepsy and other cases, mapping cases, cranial nerve monitoring, sphincter monitoring for anal sphincter and urinary sphincter to minimize any postoperative sphincter deficit, speech mapping, motor mapping, mapping of the pain surgeries, dorsal column mapping, and corticospinal tract mapping, sensory mapping, and motor mapping of the. So I'm just going to go a little bit, just going to touch that to see, to show you how, if you're familiar, if you're not familiar with that, if you're familiar with that, so you can refresher. So somatosensory evoked potential are the potential which are traveling upward, ascending toward the brain. So we can stimulate all the four extremities. Even the surgery is a lumbar area, we still monitor the upper SSCP because the positioning of the patient can cause change. Pressure on brachial plexus or ulnar notch or even the area can cause changes and which are unrelated to the surgery, but patient can wake up with those deficits. So we now monitor as a control also for make sure there's global comparing with the global changes. So we are stimulating the left hand and right hand and left foot and right foot. And we have like on popliteal fossa behind the knee, we place electrode on the lumbar potential, we place electrode on the scap, on the somatosensory cortex, we place electrode on brachial plexus, and we do recording. So the three types of recording, we do one for periphery, we do one for brainstem, and one we do for brain, and we compare. So we know if there's a change in one we know the change is between at the distal side, at the spinal cord or brain or whatever. Motor reward potential is another modality which is done by stimulating the brain. So we place the electrode either on the scalp. So if you put on the scalp, it's called transcranial motor reward potential. And if we can stimulate the cortex directly, the direct cortical motor reward potential. So once we do that, so we have two options. We can record directly from the spinal cord. If the spinal cord is exposed and has to be above because that after T9 start tapering and the corticospinal tracts are getting smaller, so it's not possible to record directly from the spinal cord below T9 level. But anything about C1 to T9, cord place the electrode on the epidural space or subdural space. And then we can also place the electrodes in the muscles and record the signal. So once we stimulate, we are stimulating the brain. So we place multiple electrodes, 2 or 4 electrodes on the cortex, and then we stimulate, and that activates the corticospinal tract. So that's activation causes the signal to travel, and then we get these responses from the spinal cord, and then we get response from hand, leg, foot, and all the other muscles which are being recorded for the surgery. Electromyography, EMG, is another test we do. So we use the same electrode we are using for low potential. We place the electrode inside in the muscle, and all these electrodes are placed when the patient is intubated and under anesthesia. So we don't place any electrode unless it's surface electrode or sticker electrode. We can place before this patient is asleep, but all the other electrodes are placed after the patient is asleep. So, and then we can record 2 types of surgery. These are to monitoring the cranial nerves and the peripheral nerves, and we do free run EMG or spontaneous EMG, which is a passive recording of the activity of the muscles. So we can tell the patient is getting lighter or the nerves are getting irritated or any traction on the nerve. And then we have evoked or trigger EMG, TMG, which can be done by either monopolar, bipolar, or tripolar stimulator. It is to identify the nerve, to trace the nerve, to confirm the integrity of the nerve, for testing the pedicle screws, and so the electrical stimulation travels through the nerve and go to the muscle, and we can. So here we can see the EMG from the left side in blue, the right side on the red, and there's a left side that the nerve is getting irritated, so you can see different 5 of these fibers. So application of EMGs measure in the spine cases is to test the pedicle screw at cervical, thoracic, and lumbar level. So if the screw has to be in the pedicle and in bone, and if you stimulate the screw with the current, it takes much higher current to get a response because the bone has insulation. But if there's a micro breach or major breach, the threshold drops significantly, and then we get these responses at a very low current. So we can identify very quickly and more high accuracy than the C-arm. The C-arm has accuracy. O-arm has a much higher accuracy, but the trigger EMG and neofunctional have much higher accuracy. About the literature says about 96% compared to 65% in the C-arm. So another modality we use is brainstem auditory low potential. This is the hearing test. We are doing that. And the purpose of doing these is to protect the cochlea, for cochlear protection during surgery, so there's no damage done to the cochlea. Or if there's ischemia or any pressure on the cochlea, we can identify on time. That. Also for the cranial nerve, auditory nerves protection, no traction. If it's a acoustic neuroma, vestibular schwannoma, or a meningioma, I mean, there's a pressure on the nerve, we can identify because you don't have to lose the signal. Even the delay of the signal or for a longer time can result in postoperative hearing loss. And also for the brainstem protection. So brainstem pressure on the brainstem, because it's traveling from the brainstem, we can identify the surgery which are being done in the brainstem and minimize that. So these can be done in posterior fossa tumor, brainstem tumors, post-ventricular tumors, all different procedures, we can identify that. So just giving you an example, in US, in early 70s, with without any type of monitoring, the risk of hearing loss post-operative was has been reported up to 38%, depending on literature, but as high as 38%. So somebody decided to let's try to do in early 70s, and let's try to do auditory evoked potential during the surgical procedure and see what uh, can be done to minimize that. And after introducing auditory evoked potential during the surgical procedure, the risk dropped, the post-operative hearing dropped from 38% to less than 1%. Now, if you're doing intraoperative monitoring and using auditory evoked potential in these procedures, the nerve is at risk, having a post-operative hearing loss risk, depending on the training and the experience of the team, can be less than 1%. It's a big drop. Another modality we use in this one is EEG mentioned earlier, which is electroencephalography. Electroencephalography is direct recording from the scalp. We place the electrode according to the International 1020 system on the scalp and record all the lobes, frontal, temporal, occipital lobe, and we can identify we can diagnose or we can see the ischemic changes during the surgical procedure, or we can also do it's a continuous recording, it's a passive recording. We can identify any type of cortical perfusion. We can also identify the depth of anesthesia, and we can give a feedback to the anesthesiology team. Patient is deeper or lighter, or if there's any risk of seizures happening during the surgical procedure. We can also record direct from the cortex, and that would be electrocardiography. So we will be doing electrocardiography. We are doing exposed cortex, and then we place on the cortex and record the activity. It has higher precision, and it is done to identify the focal of the seizures, and also done during brain stimulation. We are monitoring and to identify that patient is not having after discharges, if not seizing due to the stimulation. Visual evoked potential, another modality we use that is very common use of visual evoked potential in clinical setting to identify peripheral neuropathy or multiple sclerosis or any type of visual deficit. It can be applied intraoperatively for all the surgical procedures, but for intraoperative, we use only flash VEP because we cannot do checkerboard. Patient has to be awake and focus. So we use goggles and stimulate the eyes with the flash LEDs, and can record from the retina electroretinography. We see on the left, right upper corner, and then the right lobe. This paper we published from the occipital lobe. So, but for clinical, we can use for any type of lesion, but intraoperative we can use only for pre-chiasmic lesion, because post-chiasm, the fiber from left and right side, they mix, so it's not easy. It's difficult to identify a focal lesion. So any frontal lobe surgeries, pituitary tumor, ophthalmic aneurysm, or frontal lobe tumors, any surgery, we can use visual evoked potential in these patients. They're very sensitive to anesthesia, so you have to be very. And we have more list of, so I just went to the few of them. So due to the time limit, so we have all other modality which were listed on the slide. But the main, each modality has pro and cons. The limitation, because sensory fibers can monitor only sensory pathway of this, for example, spinal cord. So the spinal cord dorsal columns are in the posterior column, and the motor fibers are more lateral and anterior. So there's a damage in the column, it's not going to affect SSCP. Or same if there's ischemic changes, the column is not going to affect your motor evoked potential. So that's why the purpose is always doing multi-modality monitoring. We do as many modalities depending on the procedure. So fine procedure, we do motor evoked potential and EMG. If it's a brainstem, we do EMG, we do motor potential, we do auditory evoked potential, and we do EEG as well, and sensory evoked potential. So for simple procedures, so we have a multi-modality monitoring protocol with SSCP and MEP and ABR and the EMG and trainer for each. But these modalities change depending on where the surgery and what type of structures are risk, so we can use different. So again, as mentioned, there are pro and cons. So SSCP allows continuous monitoring throughout the surgery of all the sensory pathway from periphery, brainstem, brain. It does not prohibit use of neuromuscular blockage. So if you give muscle relaxant, you can still get actually better response because the muscle artifact drops. The con side is by signal averaging, it takes 2 to 3 minutes to get one response. We can short it out, but minimum at least 1 minute to get a response. So it's not spontaneous. Uh, Individual nerve root function are not possible most of the time. We can do that in selective cases. The roots are exposed. You can stimulate the roots directly and see the direct nerve sensory evoked potential. And then other direct motor changes. So motor, if there's a motor change, we cannot identify the motor changes in these SSCP. TCMEP, the pro side is monitor entire motor pathway. So if we do transcranial or direct stimulation, we can get the information about the motor pathway from the brain, brainstem, and peripheral nerve to the muscle. It doesn't require averaging. You do one single pulse in few milliseconds. Doesn't even take second to get a response. It is very sensitive. It's much sensitive to detecting any ischemic changes to as comparing to SSAP. More precise than EMG as well. It also very more sensitive than detecting spinal cord ischemia and even single nerve root injury. In the past, motor evoked potential were not done lumbar surgery because everyone thinks that, okay, there's no motor pathway. The lumbar area is just the nerve roots, and so we're doing SSCP and EMG. But all the new literature, they are confirming, and we did our study too. So the motor evoked potential are more sensitive than SSCP in identifying single nerve injury uh, in these lumbar cases. On the con side, um, MEP cannot be done continuously because every time you do, the patient jumps or have move, depending on the patient or the team and the placement of the electrode. Sometimes patient doesn't jump that much. Sometimes you have to change the parameters. So you can do that, but it's still not continuous. It's like every 1 minute or every twice a minute or 3 minutes, every 5, 6 minutes. So, but it should not be done more than 4 or 5 minutes apart. So, because if there's ischemic changes, and you're doing motor evoked potential every 15 minutes or 20 minutes, patient is already compromised during that time. It also prohibit us from using neuromuscular blockage because if you use any muscle relaxation, patient will not, muscle will be paralyzed, so we are not going to get any responses. It is very sensitive inhalational agent, so we are limited to using total intravenous anesthesia with propofol and remifentanil or fentanyl. So that's another issue with the motor evoked potential. EMG give us real-time feedback during the function. It is very sensitive to nerve injury. If it is combined with SSP and MEP, it improves the specificity of the monitoring. On the con side is sensitive temperature changes. So if there's a patient, nerves will get cold, warm, it stops firing. It has high risk of false positives. So you get a lot of time, you get EMG firing, but this could be not related to the post-op deficit. It prohibits use of neuromuscular blockage, so you cannot use muscle relaxant when you're doing EMG. Now, EMG, only spontaneous EMG should never, if it's, then we should not rely on that, that if there's no EMG firing, the nerves are okay. So if you damage the nerve, or you cut the nerve, you stretch the nerve, you might get a lot of firing, you may get only burst activity, you may not get anything. So if you want to confirm the integrity of the nerve, during the procedure, after procedure, we have to have a trigger EMG. So trigger EMG, we have to stimulate and record from the muscle. So it's very high sensitivity to medical wall breach. It's very useful for identifying the nerve roots and corticospinal tract. It's minimal invasive surgery where the surgeon going blindly under the radio imaging. It can, and if you have electrified probe, so you can identify those probe and redirect without damaging the nerve. On the con side, the same. It has a trigger EMG threshold, which can change during the patient. If patient have chronic irritation of the nerve, the threshold will be increased. It's less sensitive for thoracic pedicle screws than for lumbar screws. There's different techniques to do that thoracic screws, which cannot go much detail, but it used, and again, we cannot use muscle relaxant. Anesthesia, we also need to talk about anesthesia because we are using a team, we have a surgeon, we have a neurology team, we have technologists, and we and the nursing team. So we have to work all together. So it's a discussion to use a TIVA or inhalation agent because inhalation agent has significant effect on synapses, and they block the signals at the synapses and the cortical synapses level on motors and sensory. So most of the time we prefer using propofol infusion, except for some cases such as carotid endarterectomy, where propofol might not be as helpful as inhalation agent, but then we have inhalation agent. So why we care about that? The reason we care about this is that we want to obtain good signal because we want to have adequate signal to noise ratio. We want to have as less noise as possible. We want to have reproducible signals. We want to repeat the signal without any interference from any with minimal variance. The responses are well interpreted, so we can interpret, and we can convey the correct information to the anesthesia team. So improving the surgical outcome. So how we can apply all these. So I'm just going to go into different type of surgical procedure. For example, spine surgery. So one of the case we did that. This was kyphoscoliosis case, and we published at when we are doing vertebral column resection. So nerve is hanging in the air, and we are trying to correct this patient. So this is a high-risk procedure for damage to the motor sensory function. So having an intraoperative monitoring for these patients can help. Cervical fusion, posterior cervical fusion, lumbar fusion, anterior, posterior, lateral, oblique, pedicle surgeon, all the orthopedic surgeon, they put the motor fibers and sensory fibers at risk and nerve root at risk. So having these modalities can help the surgeon and the patient. Trauma patient with trauma can also, some of the patients I monitored the images depending on their function. So they have function, may not have function at all. So this is one of the patients we published simple degree and sensory vocation and EMG. We have a good baseline, and during surgery, after placing the 6th screw, we lost motor potential in both legs. So we stopped the surgery. We out the screws. We took out the rods, and we increased the. We gave dexmet steroids about 25 milligram. One leg came back. We did one of the very few wake-up tests we have done because we don't do wake-up test. We have good motor potential. So one, not the other, female. So we took the cancel the case, took all this. Patient was intubated. Took the patient to the MRI. Got a call from the surgeon and went to MRI. So this is the post-operative image of this patient, and this is TSF was out. So this patient has a micro infarct at T9, which and screw touching and have caused any small ischemic changes, and so that was loss of MEP both legs. So, but the signal change was less than, so the time between MEP was 1 minute and 50 seconds. So we were doing MEP every 1 or 2 minutes, and this time it was 1 minute 50. We had MEP, and after 1 minute 50 seconds, we have no MEP. And because the ischemic changes, we picked up that and we removed the screw and did the correction. But so patient woke up with no movement, but within 24 started moving. 1 week she has full power. And so we published this paper as a case report. Tibial fibular osteotomy. So when we are doing these osteotomy patients, so they have a bent knee, and you have to go and take a wedge of the bone out from tibia and fibula, tibial osteotomy, and then the high risk of peroneal nerve entrapment. So the first time I monitored this, I was doing the orthopedic case in Washington D.C. with one of the surgeon, and he had this tibial osteotomy case posted case. So I asked him, okay, well, have you done any monitoring? He said, no, I don't do monitoring. I said, do you have any deficits? He had a very high 40-50% patient the big foot drop. And so that's very high. Why don't we do monitoring? So he was always, oh, you can monitor. I said, yes, we can monitor. There's a nurse there, so I'm nurse of course monitor. So we monitor the first patient, and we have changes in those patients, SSCP and MEP, and that was inform the surgeons, and then surgeon identified there was a nerve entrapped, common fibular peroneal nerve. So he removed the nerve, the signal came back, and we did 18 patients, and we published a paper, and we have 4 patients with changes, 3 with the nerve entrapment. One, the tourniquet was too tight on the thigh, and that caused ischemic change in the left. So we identify all 4 of them, and none of the patient woke up with any deficit. Um, So orthopedic shoulder surgeries, which are not routinely monitored, so they also put the nerves at risk. But are working on the brachial plexus, so have all the nerves at risk. So we did this protocol and started monitoring, and then we published 2 papers on that. Use of ulnar nerve, radial nerve, posterior nerve, SSC, and monitoring EMG from deltoid, pectoralis, bicep, tricep, and FDI, and did MEP and trigger EMG and trainer 4 from these muscles. So regarding the sensory evoked and motor evoked potential, we were monitoring ulnar nerve, posterior radial nerve, posterior tibial as a control. We also do musculocutaneous and radial and axillary nerve. So all these nerves for motor and sense function, and to minimize. So we did publish this paper as well. So we have um, uh, so these are cases, picture from the paper and from the cases. So we did a lot of placement, and we published this paper for orthopedic surgeon, and we have uh, only one patient have post-operative weakness, and that was because the brachial artery got ruptured and have bleeding, and we lost all the signals, and we have to call the vascular surgeon, and came back and did that. And then that patient also recovered. So shoulder surgeries are one of the surgeries where we can do intraoperative monitoring in these procedures. So, I'm just mentioning hip procedures, but total hip procedures, acetabular fractures, sacroiliac joint fusion, where we put a long SI screw uh, subcutaneously, and you go long screw through the one side to the other side. So having trigger EMG and redirecting can help. So sciatic nerve is risk, femoral nerve is at risk, saphenous nerve has high risk on these procedures. So we monitor all these nerves, and we have published this paper as well. So monitoring channel 4 for the muscle action, and then ulnar nerve we do for positioning, because ulnar nerve is at risk of positioning due to pressure on the ulnar notch and brachial plexus. So we do peroneal nerve monitoring, tibial nerve monitoring, saphenous nerve monitoring, and we do recording for lumbar potential, and we do motor evoked potential as plus the EMG. 50% changes were due to retraction on the nerve. 25% was due to anesthetic changes, which we corrected, and 25% changes were due to ischemic changes to the limb. So all these patients, glad that none of them woke up with any deficit or everything. Right? So we published this paper. So not limited to orthopedic surgery, could be done for other surgeries, neurosurgeries as well, is use of longer needles, because some patients they have higher BMI, and if they have BMI, that regular use needles are only 13 millimeter. So if you're using 13 millimeter on the patient, I can see on this right side. So if they have high adipose tissue, the needles is not going to reach that, and if you are recording spontaneous EM, motor evoked potential, we are not going to get any responses. So we did studies on these patients. used all these electrodes. Actually, we used 37 to 13 millimeter electrode comparing to 13, and then one patient has high BMI, so we added 50 millimeter electrode. And on the left side, so again, for the sake of time, on example, so 13 millimeter is the first response. We have zero response. 13 millimeter electrode did not have any digital movement, or 25, even 25 millimeter, we have a response which is about 115 very small response, and 37 millimeter picked up very nice multi-phasic response at approximately. So if we have used only 13, we have and could not monitor or missed information. So using the longer needles for BMI is an option. So if you're doing monitoring or if you're interested in monitoring, so you have to use selecting the right people. For the neurosurgical procedure, so tethered cord is one of the procedures where neuromonitoring is highly used, and so in expediting the procedure and identify, because all you have to do is find the phylum. But finding the phylum in patient in babies, can be difficult because of all the roots. And if a patient has or meningeal seal or lipomyelomeningeal seal, it get more complex. But having trigger lesion not only bulbocavernous reflex, which is the reflex of the pudendal nerve, and then he can procedures. So as a protocol, we do EMG monitoring from lower limbs and sphincter muscles. Now, in the past, we were doing only anal sphincter muscle because we put another. Now we have specific electrode. We can put the electrode in the urinary bladder, and we can record because these patients can wake up a urogenic bladder. And if you're not monitoring, because roots going to the urogenic bladder are different than the one going to the anal sphincter muscle. For 3, we do other SSCP for the upper extremity, then we have posterior and pudendal nerve, and can do a peroneal nerve SSCP. Bulbocavernous reflex is always a good addition and should be also added. And sometimes we do HREs, which is so this is one of the patients we monitor. So you can see the patient, they have a little tube defect, and this have big fat tumor, and this is a big phylum is very be spontaneous EMG in the middle. We have trigger EMG, so the stimulation we are getting responses from the muscles, and then we have train of force, so monitoring the level of the muscle activity. Yeah. So the patient published, this patient went to multiple surgical procedures, and 6 cases it was done without monitoring, and the 7th case we did the monitoring, and that the case where I lost the signal. So just lost and back MRI, and then we found that the patient has a bony spot left, and the small piece of the fiber was causing constriction on the spot. So they did another surgery before back to the scoliosis correction surgery. So these are some examples. So we can see that we are stimulating with the EMG, and we get the quad icona. This is a probe, and we get a response at 1 milliampere, very small response from the foot. And then on the right side, so we're getting response at 0.5 milliampere, and the left foot and muscle gastrocnemius and anal sphincter muscles. And then the phylum below picture, so you can see the phylum. But so when you stimulate, we are getting very high 2.5 milliampere and getting no response at all. So unless you don't get response, so you cannot just go and cut it because it looked like a phylum. It could be the nerve, or it could be spinal cord. So quad icona surgeries, they are complex procedures. So when you're working in quad icona, neuromonitoring for conus and are used, and this by doing different type of techniques. We can do TCMEP, motivo potential, we do cortical direct pudendal nerve SSP, we can do EMG, trigger EMG, bulbocavernous reflex, read and EMG, all these procedures to monitor the nerve roots and the conus and the spinal cord and motor fibers. Spinal cord tumors are one of the riskiest procedures, especially intradural intramedullary tumor, and even intradural extramedullary, they are also at risk. But one which causing all these procedures, they put the motor and sensory function at risk. So we can do sensory evoked potential, motor evoked potential, EMG, D-wave, which is a direct recording from I mentioned earlier from the spinal cord, and then mapping of the dorsal because before you make a cut, you have to find out where's the midline. So one of the best way to do that is physiological because you want to prevent the functional change. So we do the dorsal column mapping, sensory mapping, and motor mapping. Um, we are looking for the etiology of the change, which could be due to ischemia, it could be manipulation or direct injury to dorsal column or resection of the corticospinal tract. So one of the patients you can see the dura's, and then this is the probe, which is placed below the surgical procedure, and then there's another epidural electrode which is placed above these two electrodes are placed epidurally above and below and then we are stimulating the cortex transcranially and recording on this right side the blue. So the first trace is the rostral tray above the surgery, and second one is below surgery by stimulating the left side, and lower the red one is from the right side. It's hard to differentiate between the left and right side in these cases because the electrode places on the spinal cord. But we stimulate the left and right cortex separately to see it. So you can see the signal which is rostral above the surgery is earlier as compared to the second one, which is later because when you stimulate the scap, signal take longer time to go across and then the second one sometime may be smaller if the tumor is pressing the spinal cord, which is causing. So we did a retrospective analysis, meta-analysis on the spinal cord tumors and published this paper with my student. It's an open access journal and article. So if you want to more interested study, read this paper as well about the technique and go into create techniques and how to do that in these cases. Select procedures where we can, these are the procedures where the surgeon goes and the roots, but those are dorsal rhizotomy. So you're just cutting the dorsal root to minimize spasticity. So the patient with the spasticity, mostly they are cerebral palsy patient. One of the surgical treatment is to reduce the spasticity by sensible. So you can do rhizotomy. But if you cut the good one, that one that make it worse. So we can do selectively. We can stimulate these fibers. We can split each root into rootlets and then stimulate with the. We can see this the surgeon. We are lifting and then stimulating with the probe, and we can look at the responses and then grade the responses into 0 to 4 and cut the responses which are only grade 3 and 4, which are the spreading to the other side, and that's a selective cutting, and that can improve with post-operative rehab. So if we have combined the selective rhizotomy with the post-operative rehab, so that hundreds of papers published on rhizotomy. One of this paper just use that as a long SDR intraoperative stimulation while augmenting motor function. So so for the procedure again, we can use one for one do recording from a clinical setting, but it saturates very fast the smell taste. So we can do that, but optic nerve to glossal nerve we monitored. So visually low potential is also here optic chiasm, and we're recording from the occipital lobe. Cranial nerve again 3, 4, 6. So for the upper surgery, given sinus tumors, pre-pontine tumors, clival tumors, ophthalmic tumor, we can do that. This is so if you are doing a superior oblique muscle, we can do cranial nerve 4 monitoring, trochlear nerve, place the electrode in superior oblique above. So you can use a monopolar electrode, a bipolar electrode, a longer electrode. And so, but these electrodes have to be placed with expert person. And so you can make sure, disclaimer, don't try that just watching the video. So you do that with somebody. So you make sure we press the eyeball and move and keep the direction of the electrode away from the eyeball and toward the bony orbit, and place the electrode for recording superior oblique muscle. Um, for the lateral rectus, we can do from the lateral rectus muscles as well superior for the abducens nerve. So we can place electrode for the lateral side of the eye. So that has, and these electrodes are 90-degree curve electrode. So if you put this with straight electrode, the risk of going into this. Uh, for the third oculomotor nerve, we use the blue electrode. You can see blue electrode, which is placed inferior. You can medial rectus or medial rectus. We can place the electrode on this one. For the more lower cranial nerves, from 5 to 12, we can do this electrode. We can do, except for auditory nerve, we do auditory low potential 8 nerve. We can do potential and EMG from these nerves with a spontaneous EMG and triple EMG. This is the patient how it will look like after their setup. For the lower cranial nerves, 7 to 12, we do corticobulbar MEP. So instead of waiting for the surgeon to stimulate, we can do continue every minute, 2 minutes, remove tension and record uh, the the caveat here is that the current can spread through the skin and cause activation. So that's why we do double train. So we have single pulse and then train. The corticobulbar pathway, which is the red, so upper motor neurons to the force from the lower motor neuron going to the cranial nerve muscles. So that cannot be activated with the single pulse on patient under anesthesia. We have to use a train. So we get a response after train, but not the single pulse. That means we are getting the response from the corticobulbar pathway. So lateral spasm response, which we do for diagnosis, the patient has a hemiphageal spasm and they go for microvascular deablation. So we have to put a Teflon between the nerve and artery, but we have to make sure the patient doesn't have a Botox, because patient with Botox last 3 months, we will get response. So we increase these hemiphageal spasms or these twitches, they disappear immediately in our recording. So we can tell that, okay, the surgery was successful. We talk about the cortical spinal embolization. So all the spinal AVM embolization. So we talk again um, interventional procedures for the, so we can do selective WADA testing, just like WADA for the brain. We can do WADA for the spine. We inject for lidocaine and see if there's a change in SSCP. If there's no change, we can do permanent embolization. If there's a change, that means you cannot embolize that feeder, because patient will have post-motor deficit if you do that. Cortical mapping has a big neurological procedures where sensory function, motor function, language function are addressed. And epilepsy mapping also, we can do map out the brain, the sensory part, language part, and motor part, and give real-time feedback to surgeon while operating there. We can give this is brain shift is not picked up by the navigation, but we can use the neurophysiological testing and pick up that. So the major goal of using the neurophysiology in these cortical surgeries is to maximize the tumor resection for improving the patient outcome and to minimize post deficit to improve the quality of life. So we want to improve the quality of life with maximizing the tumor resection. We don't want to leave any tumor, because if you're doing mapping, then you are afraid or you are reluctant to do the maximum and have, because we cannot predict the patient have tumor. So this is the protocol depending on the structure at risk. Sensory mapping for phase with reversal, we do direct cortical stimulation. With bipolar or monopolar stimulation, we do electrocardiography, we do EEG, EMG, and train of 4. So you have to plan out these procedures. The sensory mapping, we place these grids. We can come in different sizes, 1x4, 1x6, or 2x8. We place the electrode and we record, simulate from the nerves, and record from the signals. So when we're recording the signals, these signals are placed on the across the central sulcus. So this red is the more primary motor gyrus here. Um, so So this red one is, sorry, postcentral gyrus. So we have the signal going up and down, and the premotor gyrus, the same thing. These are not motor signals. These are sensory signal picked up by these contacts from this. They reverse the polarity with a 1-2 millisecond delay. So in reverse polarity is between central circuits. So that's the functional change. And that phase reversal could be, it's not always on mm, the anatomical center. So I have patient where I have phase reversal two gyrus anterior to that. If the tumor under that it pushed the corticospinal tract two gyrus anterior, and without knowing, surgeon could have gone straight to the motor. For the motor mapping part, we stimulate. Once we have the sensory mapping, for the motor path, we have to stimulate the brain and confirm it's a hand area, face area, arm, legs. So we do two types of stimulation. One is span field stimulation, which using bipolar handheld stimulation. It has high risk of seizures comparing to the other method, the Neurology method, which is a high frequency, low pulses. So pen field is low frequency, high pulses, and it is the only one language mapping. So we can, because language mapping, we ask the patient to do language tests and then stimulate the patient. So this is responses using the Neurology method, Penfield method. Here we can see the surgeons and they have bipolar probe stimulating and electrocardiography, the stimulation artifact, and no after discharges. This is a patient data from motor potential with using low frequency, only few pulses. It has very low after discharges. Subcortical mapping also, the team once you go in the white matter track, we can stimulate with the monopolar stimulation. And the theory is that every 1 milliampere current is equal to 1 millimeters. So we have to stop at 5.7. So if you get response at 5 or 7 milliampere, so you have to stop because you're less than 5 millimeter away. If you go further away, the data shows that patient will break up with a deficit. So that doesn't apply to the cortical responses, only for subcortical. Language mapping, so we can stimulate the motor stimulation, do electrocardiography for the Broca's areas and Wernicke's area, and if there's any damage to that area, or stimulation will cause aphasia or slurring or hesitation, and we can identify, and many times these language area, they are not used. They are spread it apart. So having a continuous monitoring can help these doing surgery. We have multiple tasks we can do that for like rote language tasks, noun word tasks, phrase repetition, object naming, sentence building. So all true, false, all these tasks. We ask the patient to do those tasks and we stimulate the brain and then. So we mentioned the dorsal column mapping. So dorsal column has sensory and motor fibers. And then when we are, if the patient has a tumor or for tumor resection or for the small cord stimulated plant, we want to map out that. So this is one of the patient data from papers published by Delitus, stimulating the right side and getting responses in a different waveform, stimulating the midline, then stimulating the left line. So when we stimulate from the left to right side, the signal change the polarity from down and up, it becomes up and down. If you're doing motor potential, you do the same stimulation and we can get response from the right side, you're getting response from the left side in muscles, and the midline, we get response from the both side. So we can do that. And same thing we can use for the spinal stimulator implant. We can use these in testing place context and then stimulate with the MEP and look for the responses, and we can localize the area. For the neurosurgery, brachial plexus repairs are another procedure we can do. Uh, Identify the nerve. This is a response stimulating a direct one root and getting response from sensory area. We can also do trigger EMG because we want to have identify the nerve. So we are doing the trigger EMG in these patients. So we are stimulating and we are looking at these responses and we can identify which fiber is that. Ulnar nerve transposition is another procedure where for the ulnar notch, with severe pain due to ulnar entrapment. So we can do multiple modality, and the surgeon makes the incision here and then take out the nerve under the pressure area. We publish this paper as well. well, it's not published yet, so we have presented the paper, sorry. So although not a position, we can do now monitoring motor potential from unilateral. We did this successfully and published this paper because a spine procedure. So we had mix of spinal cord tumors, conus tumors, stellar cord, spinal fusion, spondylolisthesis, and we use that data for and we have good monitoring. We also use the trigger EMG. So we published this paper for trigger EMG. So these are the electrodes which is embedded on the nerve on the on the catheter, and when placed on the catheter, we can record from the external urinary filter. And these electrodes are plugged in, and we can do more. So these are the responses from urinary bladder. Protective are the ENT surgeries. So the application and this is a probe, monopolar probe. The surgeon we are recording from all the types looking for the thyroidectomy, thyroid surgery. So thyroid surgery put the recurrent laryngeal and superior laryngeal nerve at risk. So we can record from the cricothyroid muscles and record muscles. This is one of you can see recurrent laryngeal muscle, and we are stimulating and then get responses from the left and right side. Hypoglossal nerve monitoring is done now. We published this paper. We stimulate for implant for the patient with apnea. Hypoglossal implant can cause contraction of the muscle during the sleep and decreases the sleep apnea and the risk of stroke and cardiac issue. So we did this retrospective study and published this area. Laryngeal adductor reflex is also another technique. We can do that. So in the CPA tumor where the vagus nerve at risk, we can use the endotracheal for contact, and we can stimulate from one side and record from the other side. Um, so improve. So all these techniques, there's a strong evidence. So this is one of the Dr. Michael Fellings. There's strong evidence that IONM is sensitive and specific to detecting the intraoperative changes. Another paper which said about the knowledge, which is a different one, which talk about the knowledge and experience of the neurophysiology in the operating room and comprehensive training of monitoring technologists and active communication between team, tailored approach suited to aim the INM will contribute greatly to accuracy of the INM. So experienced INM team and the knowledge and their expertise can also contribute. So anyone going to help. So it's going to help you having without monitoring. But if you have two teams and small, the risk of the neuro damage is much less. So paper by Fan. So they talk about the C5 nerve injury, which is very one of the commonest injury in the cervical case. So potential and EMG to minimize that. Upper limb acid positioning related to injury lumbar, and so in this paper they have risk of 5.2%. Patient have it has been reported as high 18% in some people's postoperative deficit. This paper by your SFP monitoring teams had fewer than half as many neurological deficit monitoring experience. So if you're comparing the team which have more experience, 50% risk per 50% per 100 cases compared to so we did University of Virginia, we published this study on patient, and we identified 32 patients with the changes, and 3.2% alert, and we identified that, and only we corrected most of them. So for the tibial osteotomy paper I mentioned, we have 22% alert, and then we identified those, and we have 0% postoperative deficit. This is a genitofemoral nerve lateral features, because genitofemoral nerve is a very high for the most affected nerves during the minimal invasive procedure, because more lateral and should be monitored, and it's not being monitored right now. So this is a technique paper we published using the cortical motor triphasic model can minimize the risk of seizures intraoperatively, and we can do better monitoring. Patient with Ehlers-Danlos syndrome, EDS, at very high, they have connective tissue disorder, they're at high risk. So neuromonitoring in these patients is very, very critical and should be done to help them identify the patient, because that patient can go into ischemic uh, issue without any have to do with surgery. Spinal cord embolization, I mentioned that. So using the intraoperative monitoring, these embolization can do a selective embolization instead of doing total embolization and waiting for the end patient not move or having the patient awake. So we need the patient awake, and we can do that. So this paper talking about they did a study on 7,800 patients, and they have 35% alert in these patients. And the severity of the post-operative injury was 100%, and severity was 100% in these patients. So, these are the two papers we published about triggering EMG and motor potential from sphincter muscles in the spine. So we can also do distal saphenous nerve SSCP on lateral surgery, because nerve and saphenous nerves are at risk. So we can we that with a high precise with the distal stimulation side comparing to the proximal one, which give you better responses and more easy to do that. We did another study in positioning, just positioning of the patient, nothing to do with surgery. We did review the 6 and we have 3.4% alert in these patients. And all these alerts were informed, and zero post-operative positioning injury in all these 6,000 patients. Mapping of, if you want to do more studies on mapping of the language cortex, we can go to that. And a point I was trying to make earlier was lumbar spine surgery. Now, motor potential, more sense. There are very papers recently. So this is our paper we published. We did a review on 1,100 patients, and we had 11% alert, MEP alert, and they were identified, and we minimized the post-operative deficit. Hypertension, anesthesia has a significant effect. So hypertension is one of them. So hypertension, so if the patient, so these are, you can see the signal, the green one is the baseline, the red one are the traces, and the yellow one are the traces after drop mean artery pressure from 103 to 76. So this is before the surgery started. So this patient has 76 mean artery pressure, which was very good pressure. But we lost the signal, and the reason was the patient was hypertensive preoperatively. In a normal tensive patient, a mean artery pressure of 80 is a good pressure, and so we want to stay above 80. But if the patient is bleeding, bleeding due to surgery, so the surgeons mostly want to decrease the blood pressure to. Once you go below 80, you are putting the patient at risk of scalp ischemia. So, and below 60, then we have significant effect on ischemia. So you have to, when monitoring the spine cut, can help them. Here we can see the changes in the lower and upper SSCP. So on the left side, we have anesthesia changes, where the signal, when the signal changes anesthesia, we see the signal changes upper and lower limbs, and both sides. But on the right side, we can do surgical event responses in cortex and cervical level on left and right side. You can see the signal getting smaller and then longer, getting longer, and then so the surgeon was immediately alerted, and the detector was detected on the brainstem and removed the detector, and that's why it's called the signal started appearing and then got earlier and bigger and came back to the baseline. So without the monitoring, nobody has known this, and patient will have bilateral deficit. Here we can scheme changes on the left side. So you can see the baseline, green baseline, and suddenly drop in the signal, and then the surgeon was alerted, and then signal came back. Positioning related changes here, the red arrows drop in amplitude with alert, the arm, both and proximity, right alert was repositioned, and repositioning the signal came back to the baseline. If you have not done that, pressure on the brachial plexus or ulnar nerve for hours and hours can result in post-operative neuropathy. On the right side, there's a nerve traction, and the sinus nerve is a hip case. where the retractor was pressing on the sciatic nerve. We released the signal came back in the green arrow. These are the triggering and motivo potential response from the disposable urethral electrode. So, diagnostic purpose, intraoperative multimodality monitoring has very high sensitivity and specificity. So, papers by published for many years, and they range from as high as 100% to 85% to say 82%, 82% to 100% range, depending on the study, the accuracy. And by combining more than one modality, it decreases post-operative deficit and increases the post-operative uh, accuracy. So multimodality modeling with SSP and PEMG in spine cases, these are people published about the spine, but for the brain surgeries or brainstorm surgery, or even cardiac surgery. So one uh, different surgery which I did not mention because of time was cardiac. So cardiac surgery or carotid endarterectomy, I mentioned in the slide, but that didn't go into detail. Carotid endarterectomy or the procedure with the temporary clamp can cause ischemic changes, and the patient has risk of post-operative stroke even up to 1 month. So there's a risk of, so we can do SSCP and E, we combine both of them, risk of stroke increase significantly as compared to the data shows that if you do only one compared to modalities and then you add transcranial Doppler, you can even count the number of emboli. And we also published paper on that one. So if you do more than one emboli per minute, so you have to do the manipulation. Otherwise, patient will have maybe cognitive deficit or paralysis. So if the patient who have changes in carotid surgery intraoperatively, they are high risk up to 30 days. So you have to continue and do the EEG and all the monitoring and cognitive testing on these patients. The positive predictive value and the negative predictive value during the papers published on the spine surgeries very high. One paper published by this have PPV of 100% and NPV of 97%. And the other paper, they again, they talk about positive predictive value as low as 63%, depending on some patients with as high as 80%. But combining the multi-modalities that increase the positive predictive value and negative predictive value of patient. This is a paper we published from the, and so the in US, the one of the most common way to do monitoring in two teams. One is the supervisor physician and one is the technical team. So the technical team is in the OR and the supervisor neurologist or neurophysiologist either in the OR, or it could be remotely, because we are trying to provide services. With the hospital muscle surgeon, it's impossible to have one neurophysiologist for every single hospital necessary. So majority of 70+ surgeries are performed with the remote supervision. I can take over the computer and can do brain stimulation, spinal cord stimulation without the technique allow us to do that. So and then we have published this American Society of Neuromonitoring. It's published guidelines for supervisor professional, and they should be adhering to guidelines for the best patient outcome. So these are other published where they published paper on the use of IONM 50,000 patients and less than half of death. And they reviewed in 50,000 patients, and the deficit was less than half in experienced team versus non-experienced team. Now deficit is much higher if there's no. So I like this quote from one of the previous pods in the room and ENT surgeon, Dr. Kaptush, about the quality that poor monitoring is more dangerous to patient safety than no monitoring. That's why always provide superior monitoring. So when you have no monitoring, as a surgeon, you are more alert. There's no guy. Somebody's monitoring and they're not doing a good job, then you're depending on that, but they have loss of false negative, and that can result in more dangerous situation. So if you have to do monitoring, then we have to make sure we are doing this very superficial. So this is the remote physician protocol where we can provide services to multiple hospitals and multi-surgery at the same time. again, the limits, so you cannot do like, if you do 10 or 15 patients, then it's impossible. You can do 2 patients or maybe maximum 3 patients. But if there's a change, then you have to focus on one, and you have to ask somebody else to cover the patient where there's no change, and you have to be more dedicated um, line to the one person. So evidence-based practice of monitoring where applicable, we should do. There's already evidence of the monitoring, and that of value monitoring must continue to be. New models of research will lead to better understanding of value monitoring. So what we have done for 40 years is still developing, and we are coming out with the new techniques, and we can provide much better. So IONM, in summary, the IONM modality are excellent tool for intraoperative changes to minimize any post-operative deficit. So to do the neuromonitoring, we must provide in multimodality, because that it's not only spine procedure, or any position, any procedures to the maximum neurological deficit. So just giving you like idea, so that's a long time ago, many years ago, early 90s, the first machine that I used was this, which was only 4-channel. It had no hard drive, and it had this floppy drive. I don't know, many people don't even have seen the floppy drive. So if you've seen the floppy drive, you're as old as me. So you have to upload the software side, and only 4 channels. So you can limit to 4 channel, and you have to unplug SSP and plug MG, and you keep changing. So, and then we moved to another state where this is a picture from 2002. So we used Digitimer, which was the first device approved for the motor potential, and has to be, we were using as an external trigger to record from the bigger machine. So this is about from 4-channel, it became 16-channel machine. But now we have different vendors, big machines, and now they are state-of-the-art machine with 32 channels, and some of them go to 40 and 50 channel as well. So we have multimodality. We can do multiple stimulation. We can do 16, 8, up to 16 nerves at the same time. We can record up to 32 channels of 64 inputs, which can make more than 200 plus channels. So it has a big change over the last many years, and it has been have improved, and the hardware is improved, the software is improved, as well as remote connectivity, and the techniques we have. And we've been doing these courses over multiple countries for the last many years. So, as we say, so just some different workshop, we are introducing these monitoring and training people again and again, giving every year there's a new techniques come new, and the hands-on training is always very helpful with these procedures, and can help the patient. And training can also be helpful. Some recent images from the team work, they help me a lot, and doing intraoperative training for the different type of spine procedures, neurosurgical procedures. So education, and then now we have educational courses available. Educational remote courses, we can do that. So, thank you.
Thank you so much, Dr. Faisal, for this wonderful and comprehensive introduction for the intraoperative monitoring. We really appreciate this lecture, and I hope it's opened the eyes about the importance of intraoperative monitoring in the field of medicine. We believe that although the evidence supporting the intraoperative monitoring in multiple surgeries, the challenge is not only for the manpower, it's actually for the logistic. The knowledge is there, the manpower is there, but sometimes having all of these together in one place, this is the challenge. This is not only in a few countries, this is actually in multiple countries. It's have to be the right people, right machines, great communications, all of these. If it's not met in one place, IOM cannot be conducted in a good manner. Now, with the help of new technology, with the internet, using telemedicine, using a good model of operation. I think this can solve a lot of challenges that we're facing. Dr. Faisal having a great expertise in that, even monitoring places that they have challenges for the simple things in the hospital. He was able to do monitoring in these places. IOM is not only in one surgery, it is in multiple surgeries. I appreciate the audience and the attendance for coming. We have attendance and audience from multiple countries across the globes. We have from each continent, I guess, they're registered, and in multiple countries. We'll start the inquiries that we're having about the certificate. Yes, anyone registered in the link that was provided in the social media, they will receive a certificate for attendance. Regarding the recording, this webinar is recorded, and soon it will be we will put the link for the full recording on YouTube, and we will put the link for this video on Neurology Solutions social media, namely the Twitter and LinkedIn. Dr. Faisal, we're having a question that said, in case with known chronic myelopathy, what's exactly the benefit of neuromonitoring? And is it really the standard of care?
So before I answer the question, standard of care definition, thank you everyone for asking the question and for great participation. Now, so the standard of care is a terminology where we have not this gone. And the reason is, once you define a standard of care, then you have to provide that. So the only procedure where we are using neuromonitoring as standard of care for right now is scoliosis cases. So if you are doing any scoliosis place anywhere in the world, you should have the neuromonitoring is standard of care. So you should have a neuromonitoring. Other cases, there are CPA tumor, brain tumor, facial tumor, and all these cervical cases. It should be, but standard of care means that you have to provide that. And you don't have enough people, and just giving you an example in the US. So we have 8,000 hospitals and more than 5,000 hospitals. They are doing procedures every day. Every hospital is doing like hundreds. There are more than 1 million procedures. And we since the certification started by Albarrak, we have about 5,000 people certified in last 40 years. And also 5,000, many are retired. They passed away. I don't know. They retired or they are in management role and they are not doing monitoring. So less than 3,000 technicians certified, and they cannot cover even like half of the hospitals at one time. And at the board level, we have American Board of Neurophysiological Monitoring, ABNM, which certified specific neuromonitoring. We have only 190 people certified all over the world. And 190, I think only 135 are certified and 50 are retired or not recertified. So we don't even have one person for one state or one, and most of the countries don't even have that. And then there are people from neurology background and American Board of Clinical Neurophysiology. They also have sub specialty exam with neurology with subspecialty IONM, which is but not enough place. So we cannot, and there's no college. There are very, very few colleges in the world they are providing that service. So if we cannot put people in system, we cannot create this standard of care. So that's just a definition. It should be standard of care, but we cannot do that, but it's required. For myelopathy patient, so these cervical myelopathy or the myelopathy patient, these patients are at much higher risk than non-myelopathy patients. You know that. So having neuromonitoring is more critical for that. But what we need, the data shows, one Dr. Atar Hussain, he published very good literature on from Duke, comparing the patient with the myelopathy with non-myelopathy. So there's a different technique using double train technique with a different technique. So you have to manipulate the technique, but we can still get good responses and we can have a better patient outcome in these myelopathy patients. So the simple answer is yes, we should be doing that, and we need better monitoring for this patient.
Yeah, great. And as you mentioned, Dr. Faisal, we have huge variability in the IOM monitoring across the countries. It is not only about the finance, it's about the erosion and availability and the policy of these hospitals. So we can find it done for even the simple cases in some countries, and countries, even the most needed surgery, it is not done. So once there is protocols for that in one country, this can help. But the challenge is not only that. It's the challenge is finding the experts who can do it. We cannot put technician and MD in each hospital, in each surgeries, but we can have multiple monitors. We can monitor more than one surgery by one MD and a technician that who can turn over on the same surgery. So with this, we can make it cost effective for having the manpower. As you know, and the people in the field of IOM, they know that the IOM team coming before the anesthesiology last people who leave. So it's need an effort. It's efforts, but it's need effort and teamwork and appreciation from the other teams. So we have another question is that what's the role of intraoperative neuromonitoring in trigeminal neuralgia surgery?
So trigeminal neuralgia patient, there are two major procedures that can be done. One is microvascular decompression. So if the trigeminal neuralgia is due to compression of the blood vessel, which is causing touching the trigeminal nerve, and every pulse causing demyelination, so you have to go and put the so identification of the facial, because if you want to anatomically you can do that, but this one is very big. So having a trigger EMG and trigeminal SSCP in these patients can help in very quick identification of trigeminal nerve. And once you place those electrode and do, we can stimulate the gum or upper limb and record the trigeminal SSCP. We give the surgeon probe and we can give them. So that's one of the microvascular decompression. We can do precise localization of the nerve and decompress the right nerve, not the maybe 7 is already there, 8 is already there. So we don't want to decompress the 7 and then come back with the pain. The second is the implant. So we do the if they're doing ganglionic block or rhizotomy or you're doing rhizotomy with laser or anything else, so that is not, neuromonitoring cannot help you because you're just getting the dorsal root or giving injection. But if you're doing implant, which you do that for people who don't respond to the ganglionic block or rhizotomy, so we can the patient has pain in specific part of the face. So we can localize the contralateral cortex, we open the cortex and localize the stimulate the brain with the sensory mapping, then motor mapping, identify the face area and tongue area, and then place the grid exactly and the suture the grid. So the numbness of anesthesia is in the area where the patient has a pain. So we can do, so it decreases the time and it has a quick, and we know the outcome will be good.
Thank you. So we have a question is that what's the percentage if we're using IOM to minimize the post-op deficit? I know you came across this in multiple and different studies with the different surgeries, but if you can summarize the major surgeries and the percentage of decreasing the chance of developing a post-op deficit, this would be appreciated.
So one, thank you. So that's an interesting question, and that's the main focus of all the monitoring. So how much we can minimize. Some surgeons may tell you, or some people say, okay, this is only less than 3%, so that's okay. But for those patients, it's 100% correct. So those 3% patients who have to get affected, those are the they have maximum effect. So for the acoustic neuroma, vestibular schwannoma, CPA tumor, we found it was as high as 38% hearing loss. And that was persistent auditory responses, but delayed. So now the current data shows that if your wave 5 delays more than 1 millisecond, you have a high risk of deficit. Even the nerve is there, the response is there. So, but if you inform the surgeon and come back, it drops less than 1%. For the other procedure, facial nerve, for facial nerve tumor, any surgery done in facial nerve, if you have A train facial nerve, you can have ABC train. A train is more predictive of deficit. So the research says that if the A train lasts for more than second, you have post-operative facial paralysis, just 10 seconds of that. So you want to inform, so you need to have a good team who are watching the screen remotely, or they're in the OR and they're getting and then informing, and you want to stop, maybe do warm saline to refractor out whatever it's causing, or too much bovie, so it can decrease less than 1%. For extreme lateral surgeries where the surgeon is going blindly, the risk has been reported as high as 50%. So all the instrumentation company who provide these lateral procedures, they are coming with their automatic built-in EMG, because if you don't do that, patient will be paralyzed. But with the automatic system, you don't have experienced people. People who are providing, they are not trained in IONM, and they cannot do multimodality monitoring. They can use trigger EMG. So if you're doing a good system, you can have SCP, EMG, trigger EMG, and other reflexes, and you can minimize less than 1%. Pedicle screw testing, again, pedicle screw in spine cases has been reported as a injury to the as high as 9.8%, 9.9% in paper published from New York, and then reported less than 0.9%. So that's and positioning of a paper published from positioning can range from 3% to 18% published. But in our data, we had 3.24%, but it reduces less than sometimes 0% depending on study, or less than 1% again. So which has nothing to do with the surgery. The one mentioned from University of Virginia, they were doing gynae surgeries, not even neurosurgery, and patient are waking with ulnar neuropathy. They reported 7.1% risk of ulnar neuropathy. And one said, okay, can you do ulnar nerve monitoring while we do hysterectomy? So and that could be reduced less than 1%.
Yeah, and the thing that we cannot imagine any OR without monitoring the heart.
Yeah.
But there are many surgeries in the brain, and we are not monitoring the. Why not? And we can prevent a lot of this.
And many times,
Yeah.
people don't know that we can provide the service. Okay, can you do? Oh, we can do. We can do lateral rectus. We can do all these nerves. We can do pitchly monitoring, VEP, all these procedures.
Yeah. There is a question for a friend of mine. How can we enroll in the IOM diploma? In the last few slides, Dr. Faisal explained about the diploma. I hope in his LinkedIn account, he can also put explanation about that and link for registration for the IOM diploma.
Yeah, the last slide, go to recording, have the website address, globalinnovation.com, so you can go, and that's a link for the details, and you want to apply for diploma.
Yeah. For the VEP, how accurate is the IOM under GA?
So VEP can be done in under GA, and it has been published. It is very, very sensitive to anesthetic agents. So most of the anesthesiologists, they refuse to do that, or nobody will give. I have anesthesiologists agreed, but nobody gave them break. Okay, I'm not, because if you're doing VEP in inhalational agent, you need to have less than 0.3 mag. So you go at 0.5 mag, it abolishes. So 0.3 mag is very, very, and those are brain surgery, and you don't want the patient to move. So 0.3 mag is the maximum you can do. 0.25. If you're doing propofol anesthesia, then you want to stay less than 80 microgram per kg per minute, maximum. If you go more than 80 or 100, then you're going to abolish. So it is possible, but it has to be very, very dedicated team who can do that and can help you that.
Yeah. So and also
it's very reliable, and you can see changes. We see changes and inform the surgeon, and we can prevent the loss.
Yeah, and also the challenge that patient for the VAP, the visual pathway had multiple synapses, so that's having very high sensitivity to any. It's very sensitive for the anesthesia because of these synapses, and as you said, anesthesiologists wouldn't like us telling them what to do during the IM. There is a question is that what's the protocol would you use in the minimal invasive scoliosis surgery with the lateral anterior approach?
So for the scoliosis procedures, I think I have one slide, but for the minimal invasive procedure, we do lower limb SSCP from posterior tibial nerve. Sometimes we add peroneal nerve or fibular nerve. We do motor evok potential, but has to be done continuously, especially during instrumentation or correction method. So it should not be more than 4 to 5 minutes. For the schools, for the exposure part or the other part, you can go as high as 10 minutes, but the goal should be less than 5 minutes for the whole procedure. And then EMG from all the lower limbs for adductors, the quadriceps, tibialis anterior, gastrocnemius, foot muscles. And for our protocol, we have anal sphincter EMG and we have bladder EMG, because these minimal invasive procedures, patient can wake up a neurogenic bladder. So we monitor EMG on the bladder muscle as well, and MEP.
Yeah.
And also, sorry, ulnar nerve SSP, very critical for positioning of the patient.
Yeah. One question is the cost of the IONM. I think as any medical service in the world, we cannot like answer this question directly. It's depending what you would do it, what's the modality that you would do it, what type of surgeries, what's the salary of the people who will go there. We have the consumables, which is having variable prices with the manufacturer and depending on the country, taxes, these things. And so I think the cost cannot be, even if it's in one country, cannot be specified unless it was studied very well. In US, it's having one price. In each country in Europe have one price. In Saudi Arabia have another price. So depending about the surgery, the modality would be used on the surgery and the other logistic challenges that it's done. But as with every service, once the flow is more, the cost will be much lower.
I totally agree with you, but just one thing, that the multimodality approach is not based on making more money. It is because to protect the patient. And you adding more modalities does not add more cost to the surgeon generally, because it adds more work for the person, the technologist and the physician who are working there. So because the employee who's working there, that's salary employed, so they're going to make same money if they put one modality or 10 modality. They're going to work more hard. And if you are in one of the country, the insurance is paying, the patient is not paying, the surgeons are paying, hospital insurance is paying. So the multimodality cost doesn't affect that much, doesn't go that much. It's most basic monitoring which comes. Once you have monitoring, having one or two modalities, consumable are the one which is in more thing, that is the one cost only.
Yeah. We have one question is that saying doing intraoperative monitoring at OR, how to maximize single noise ratio without interrupting other teams' workflow.
Okay, so that's a good question. So that's a little technical report question, but there are so multiple resources of noise, and most common is the electrical noise. So every equipment used in the OR, Xeon, X-ray, microscope, anesthesia machine, bed, IV fluid, bear hugger, everything is creating noise. So you have to make sure you are not close to, your wires are close, not close to. So we keep our wires as far as possible. We keep all the electrodes, all the electrodes should not be hanging. So because if the electrodes are far from each other, they act like antennas, so they make more noise. So they should be more close to them, braided together. If you have outlet, so try to use outlet which is not used by any other equipment. And the last thing is the averaging. So most of the MEP doesn't is spontaneous, but if you're doing sensory evok potential or auditory or visual evok potential, so you have to either increase the number of averages or change the session frequency, which is not divisible of 50 hertz or 60 hertz, because in US is 60 hertz electricity. And in Saudi Arabia and Europe and many countries are 50 hertz. So anything which is divisible of 52 or 1 or 5, you're going to pick up more noise. So you want to stimulate that which is a divisible number of 50 or 60.
Yeah. This is a directed question. So where to place the reference during the cranial nerve monitoring?
So I think the question is about the recording, the stimulation, correct? So if you're doing a monopolar stimulation, you can place the electrode either either you can put you can ask the surgeon to place the electrode and expose. So the best thing is to ask the surgeon to place in the exposed area under the scalp, because then you have less current spread and you can get you can place the electrode on the top of the head, depending on the exposure. You can place on the shoulder, but that will create more current spread and you'll have more sensitivity but less specificity. You will not be able to pinpoint. So more close you are to just try to make sure more. So ask the surgeon to make the marker, so they make a line that they go to exposure, and then stay as close to as possible. It doesn't matter where you are, but the electrode has to be secure, and bigger surface area electrodes are much better than electrode. Surface sticker, ground electrode, or corkscrew electrode.
So there is a question: is it possible to utilize the to provide the IOM in MOH hospital? I think this question is coming from to overcome the resource shortage in this field. Yes, please. Regarding this, it's related to the regulations. Outsourcing the services is possible whenever there is a shortage, or sometimes whenever it is not there. It's a model that's done by MOH, I mean outsourcing some services. I have never heard about outsourcing services of IONM in Saudi Arabia, but this is a very possible thing. If you can contact us through our LinkedIn account, we can figure out the way to do it. This is always possible. Neurology is the licensed by MOH to operate the neurology departments. So now we'll go to other question. How can it be distinguished between the two central conduction response and peripheral response during a corticobulbar motor recording?
I had that image in the picture, but so the way we do double train stimulation. So for corticobulbar stimulation, we have to do a single pulse and 3 pulses with the time between that. You can do single pulse first and then followed by the 3 pulses, or you can do 3 pulses followed by the 1 pulse. If you're doing 3 pulse first, most of the time, then you should have at least 90 millisecond time between the first pulse. And theory is that when you stimulate the scap to get a response, the current can come, the direct DC current can activate the muscles on the contralateral side and cause contraction. And the corticobulbar pathway goes to the brainstem. But if you do pulse, if you stimulate only one time, the motor fibers cannot be activated under anesthesia. So if you get a response after the single pulse and after the train, that means either they are both or it's only peripheral. If you get only after the train, but not after the single, then that's a pure corticobulbar. If you get only after single, that means it's a pure peripheral. So the way to do is go back to the slide. And if you want, I can share the handout for this slide. I can create a PDF and we can distribute it to get a copy of the handout of this slide. So you can go to my YouTube channel. I have the whole presentation on corticobulbar for free. So you can get that images. You can take the picture about exact stimulation parameters for the corticobulbar MEP for double train stimulation. And you just make sure you change the parameter number of pulses and decrease until the single pulse disappears, only train appears.
So this is a very interesting question, but it's the long duration for answering. But if you can make it brief, I would appreciate it. So there is one of our colleagues asking, we have the data. So I guess they mean that how to make a decision, since we have variability in some data about the critical points.
You should always have the protocol, whoever your monitoring group is, that what is the definition of a good response, reliable response, poor response, and absent. So we do not, many people, they don't differentiate, they say, okay, good and absent. So a good response is, for recipe, if your signal is more than 1 microvolt per division, that's a good response. Anything within 0.1 microvolt is a reliable response, it repeating. And 2.2 is unreliable. Anything like 0.3 is unreliable, and it's less than 0.3 isn't. Because if you pick up a very small and motor evoked potential, anything above 200 microvolts should be a good response, or reliable. Anything above 500 microvolt should be a good response. But if you sometimes you're not getting responses and you're getting very small 50 microvolt or 20 microvolt, and you're just hanging on to that rope, that will put you into trouble, because that response can disappear anytime because it's not a reliable response. So a short answer is that you have to do, you make sure you do 2 or 3 recordings. If they repeat, then that is a good, reliable response. This is not repeating again with the same amplitude latency, consider that as an unreliable response, and inform the communicative surgeon that I'm getting response, but it's unreliable. Don't give them a false hope, because again, poor monitoring is better than no monitoring. So tell them you have a good response or poor response. Even you have a response, don't say there's a good response if it is not repeatable.
We'll end up with this question. What's the role of SSAP and other neurophysiological procedures in diagnosis of MS, as it's not part of the criteria? I mean, this question is not during the IOM section, but if you have any answer for this question, Dr. Faisal.
So it's not, so for the clinical purpose, the SSP is not a criteria, but SSP can be used in addition to visual potential for any peripheral neuropathy. So for visual potential diabetes, sclerosis. So I cannot go into more precise. I don't want to give some wrong information, but I'm not a board certified in, I'm more in intraoperative physiology. So, but again, usually potential alone is not going to help you, because you have to use with clinical and MRI and imaging. So you can add, so SSP is a good addition to the other diagnostic tool. In addition, that gives you confirming the patient with multiple sclerosis.
Yeah, now it is outside the OR. It is less than before, used with the help of MRI right now. It's not as before in many clinics. I know there are some still using it, but maybe used currently in intraoperative monitoring. Someone is asking how to get the contact of you, Dr. Faisal.
My email faisal.global.innovation.com. Again, it's on the last slide, but I'll type in the chat box. So. And you can just Google my name, go to my website, and I have a link there, so you can just reach out to me.
Sorry if there are some questions and we did not answer it because we have a limited time. We hope you enjoyed and learned from this lecture, and we hope that we will conduct another webinar in IOM and other subjects in neuroscience. Thank you for attending, and see you.
Yeah, thank you, Dr. Anas. Thank you everyone for the